Hello everyone. Today we're going to talk about complete denture synopsis from dental pulse, starting with the classification of soft palate. So this first is the classification by Dr. House. This says that there are three classes of soft palate, and it depends on the angle made by hard palate with the soft palate. Suppose this is your hard palate, okay, and this is your incisor. This is your hard palate, right? Now it makes an angle with the soft palate. So this is your soft palate, and if you extend this line, this angle is the base of the classification. If it is almost horizontal, then you have class 1 type of soft palate. If it is 45 degree, if it is 45 degree, then it is class 2, and class 3 has 70 degree of the angle between hard palate and soft palate. Now, why is it important? It is important because this will determine the retention of the denture. How? Suppose this is your denture, right? Now you record the posterior palatal seal area. If your soft palate is like this, you will not be able to cover more area. Okay, so your retention will be compromised. Opposite to it, if you have a almost horizontal palette, that is horizontal soft palette, you will have more area to cover, right? So it will increase the retention, and that is why it is important to have different classification of soft palette. So class 1 is almost horizontal and demonstrate a little muscular movement. Class 2 is 45 degree, and tissue coverage of the posterior palatal seal is less than class 1, and class 3 is soft palate makes almost 70 degree of angle to hard palate, and tissue coverage of the posterior palatal seal is minimum. As we have discussed, the tissue coverage will be minimum by the denture compared to the class 1 type of soft palate. Also, V-shaped, this V-shaped palatal vault will be there. V-shaped palatal vault will be usually present in class 3 type of soft palate. Second class is classification of lateral throat form. Now, what is lateral throat form? It is retromylohyoid fossa. What is this? Suppose this is your mandibular arch. Okay, this is your mandibular arch. Here is your tongue. Right now, the space between tongue and the mandibular arch or ridge, this part is called as lingual sulcus, and this lingual sulcus can be divided in three parts, right? Part 1, 2, and 3. Part 1 is called as premilohyoid, right? Premilohyoid fossa. This is mylohyoid fossa, and this is retro. This is retromylohyoid or postmylohyoid fossa. So we are talking about that part. We are talking about this part of lingual sulcus. Now, why it is important? It is important because it provides the retention of our denture in posterior area, right? So similar to soft palate or posterior palatal seal area in your complete denture, maxillary complete denture, it is similar to the retention area. It is similar to the retention area in lower denture, right? And that's why it is important. And That's why we classify this lateral throat form. How does how is how do we classify this area? We define we classify it as class 1, class 2 and class 3. Always remember class 1 will have more retention than class 2 and class 2 has more retention than class 3. How do we measure it? Class 1 indicates the anatomical structure will accommodate a fairly long and wide flange, right? So if you see from lateral view, suppose laterally this is your mandibular ridge, okay, and you have this coronoid process. This is your tongue, right? Now tongue has this part. This is palatoglossus muscle. Palato means palate, glossus means tongue. So this muscle will produce a fossa of this retromylohyoid form, that is lateral throat form. Now how much is the depth of this retromylohyoid fossa? It can be determined by one, your mirror, right? Your mouth mirror, you insert your mouth mirror. If it is completely inserted, then it can be called as type 1 or class 1. That is, it is very deep. Your flange will have more retention. This, suppose this is your denture and this is your lingual flange. So your lingual flange will be lengthy in this area, right? Suppose this is your lingual flange. So your lingual flange will be more in type 1, and that's why it has more retention. Type 2 will be, class 2 will have half as long and narrow as class 1. So your mouth mirror will be inserted half. So your palatoglossus muscle will be like this. The palatal glossus muscle, let's have a different color here. Your palatoglossus muscle have this shape compared to this. And class 3 will be almost shallow, right? It will be ending 2 to 3 mm just below the mylohyoid ridge. So as we have discussed, this is your mylohyoid ridge and it will be almost 2 to 3 mm to mylohyoid ridge. So this is classification. This classification was given by Neal's classification, right? Third is House classification of tongue size. Now there are two classifications for tongue. First is tongue size and second is tongue position. Tongue size is given by House and tongue position is given by Wright. What is class 1, class 2 and class 3 type of tongue size? Class 1 says that tongue is normal in size, development and function. Sufficient teeth are present to maintain its normal form. So basically you have all the teeth present and your tongue is surrounded by those teeth. Okay, cool. You have all the teeth and because of that the tongue is limited. Type 2 is teeth have been absent long enough to permit a change in the form and function. Now because your teeth are lost, right? Your teeth are gone. So now your tongue has freedom to move outward, and because of that, the size of tongue is enlarged. Because that size of tongue is enlarged, you will have more difficulty for retaining the denture, because tongue will dislodge the denture, it will reduce the stability. And type 3, that is class 3, is excessively large tongue, and it is seen in very poor ridge where tongue has almost covered the ridge. Suppose this is your ridge and tongue has covered the ridge part, and because of that your denture will very loose and it will not have more stability. Compared to the size, the tongue position is different thing, right? Tongue position classification is given by Wright. What does Wright say? Wright says that there can be three classes of tongue position. Class 1 is tongue lies in the floor of the mouth. So position is in the floor. Suppose this is your tongue and this is your mandible and this is your incisor. So tongue will be in the floor. Okay, this is the floor of the mouth. Suppose, and it is slightly below the incisal edge of mandibular anterior. So this is incisal edge. So your tongue will be like this, right? Tongue will be like this. Class 2 is the tongue is flattened and broadened, but the tip is in the normal position. So suppose you see from the front, so tongue is broadened. The tip position is in the mandibular, almost inferior to incisal edge of mandible anterior, but the position is almost broadened. The size is broadened. Here the size was normal. In class 3, the tongue is restricted and depressed into the floor of the mouth with the tip curled upward. So again, this is your mandibular central incisor. Your tongue is in the floor of the mouth and the tip is slightly, it is slightly curled upward or assimilate into the body of the tongue, right? So this is the classification. It's class 3. It is very low tongue. The level of the tongue is very low. This was classification by Rao. This is the classification by Wright, House. This is Neal's classification and soft palate classification. These are 4 classification you have to remember. Now second is surface of complete denture. As you know, if this is your complete denture, okay, these are your teeth. Okay. So you have first occlusal surface, which will be on the teeth. Second is this tissue surface, that is, sorry, the polished or flange surface, and third will be the tissue surface or intaglio surface. Intaglio surface. So there are 3 types of surfaces. Type the occlusal surface, the polished surface. It will also include the palate. The teeth part have occlusal surface, only occlusal or incisor. The polished surface and the intaglio surface, that is the impression surface, and we take the impression of this surface. Coming to important point, that is residual ridge resorption. It is the reduction in volume and size of alveolar process of mandible and maxilla. It is simply the reduction in quality and quantity of your ridge. Now, resorption in maxillary ridge occurs in upward and palatal direction. Why it occurs in upward in palatal direction. Let's understand. Suppose you are looking at your maxillary ridge from the front. Okay, so this is your maxillary ridge, and your natural teeth will be like this. Okay, these are your molars. If you see, this is your Wilson's curve, right? Now, if you remove this maxillary molars, what will be the direction of your bone resorption? It will be like this only, right? And because your molars are angled in this direction, the bone resorption will be in this direction only, because the shape of bone is like this. So it will be palatal, that is inward and upward. So the resorption of the maxillary ridge will be upward and palatal ward. If you want to know why this is the shape of your molars, why our molars are not in this way, why it is not in this way but this way, because you have a muscle, that is masseter. Your masseter muscle is directed palatally and upward, and because of that you need to have a parallel force, and because for that requirement your teeth is situated in this direction, and continuation to that your resorption pattern will be upward and inward. Okay, compared to this, the mandibular anterior region, now this will be similar in anterior also in maxillary ridge. If you see anteriors, your anteriors will be like this. Okay, this is your bone. So again it will be upward palatally,